It is very treatable, very manageable, but right now it is still considered an incurable disease. So patients are on this journey with myeloma for the long term. So it's very important for us to realize that during their journey, we will see them repeatedly. They are going to be part of our work family. They will be with us for a while. And I think it's our job to be their advocate, to be really focused on not just them as a disease, but like you mentioned before, periodically assessing that financial burden.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Welcome to the ONS podcast. I'm your host, Lenise Taylor, oncology clinical specialist at ONS. And today we're talking with Ann McNeill, nurse practitioner at the John Theurer Cancer Center at Jersey Shore University Medical Center in Neptune, New Jersey, about an overview of multiple myeloma for oncology nurses. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us today, Ann.
Welcome to everyone, and thank you, Lenise.
Let's start out by talking briefly about what multiple myeloma is and give an overview of its history and its epidemiology.
Multiple myeloma has a pretty lengthy history. I believe it was first documented in the 1840s with descriptions of bone pain, fractures, and this abnormal protein that was found in the urine. But it remained untreatable for a century until modern therapies emerged. So epidemiologically, myeloma is a cancer of older adults. The median age is about 69. It is more common in men than women. It's about a ratio of 3 men and 2 women that are diagnosed. It is much more common in people of African American descent, with increasing global incidence linked to aging populations, though the highest rates are in high-income countries. So if we look at some of the risk factors, and several have been identified, including MGUS. MGUS is a benign precursor of myeloma. It stands for monoclonal gammopathy of undetermined significance. Older age is also a risk factor, although we do see patients that are younger who are diagnosed with myeloma. Of course, we mentioned the male gender, we mentioned the African-American race, and there are also hereditary factors. In addition, there are some environmental risk factors for myeloma, and that includes things like exposure to ionizing radiation, agricultural chemicals like pesticides, if that is your life's work, if you're a farmer. Also exposure to Agent Orange. So we have patients who are military vets of the Vietnam War where Agent Orange was used extensively. There are weight and dietary characteristics that may also play a role in the development of myeloma.
I had no idea it had been documented that long ago. That's so wild. All right, let's talk a little bit about the pathobiology of multiple myeloma and how the cell of origin becomes malignant and how it affects other surrounding cells.
As with all cancers, I think the development of myeloma is a very complex, multi-step process. It's characterized by early and late genetic changes in the tumor cells, as well as very unique supportive conditions within the bone marrow microenvironment. So that's an important factor to remember. We have the myeloma cells or the malignant plasma cells, and then we have this very important environment in which they live that actually makes them live longer, it enhances their survival, and can cause a lot of challenges in the treatment. Although myeloma does remain incurable, the overall survival has improved over time because of advancements in the understanding of this specific biology, ongoing development of novel therapies, and technological improvements in genetic sequencing that affect the therapeutic options, and clinical outcomes. So I think it's important to remember, again, the interaction of the myeloma cell with the bone marrow microenvironment as an important factor for the development of disease. So this involves the activation of cytokines, which are soluble substances that are secreted by the myeloma cells, or the cytokines are activated to be released by the myeloma cells. There are certain growth factors and adhesion molecules in a series that adds to the proliferation and the survival of myeloma cells. The unique cellular communication between the myeloma cell and its microenvironment allows for this infiltration of the marrow, the growth, the adhesion, the migration of the myeloma cells. And it really provides an environment to create drug resistance in these myeloma cells. So it's a very unique environment between the actual tumor cells and the environment in which they live. So the actual bone marrow environment is a crucial factor in the patient's journey, if you want to call it, of myeloma, whether they respond to therapy or how they respond to therapy, how long they're in remission, and so forth.
That is absolutely fascinating. I know a lot of the conversations I've been having with people recently are about how we can prevent cancer, how we can identify it earlier, how we can keep it from taking over the body. Why can't we fix it earlier? And I think having people understand how these cancer cells can do things to prolong their own lives and to make the environment favorable to them is just something that most people just don't understand.
Yes, exactly.
What are some of the common signs and symptoms of multiple myeloma that a patient might present with during a primary care visit?
This is very, very interesting. I do a lot of teaching for other nurses and actually for patients and caregivers. And the most common presenting sign or symptom, you might say, for patients with myeloma is bone pain. And more often than not, it's their back that hurts them. So it's the spine. They have back pain. And actually, when you think of the number 2 spot for common presenting symptoms of patients with myeloma, it's fatigue. So I always talk to nurses and I talk to people in general, and I say, think about this, especially to nurses, right? How many of you have had back pain and fatigue? Everybody raises their hand, oh my God, that's me, that's me. When you go to a primary care physician and you present with this kind of picture that you have back pain and you're tired, a primary care physician is not going to say, oh my goodness, I have to screen this person for myeloma. Myeloma is not common, and these symptoms are way too common. Lots of people present like this. So bone pain, specifically the back, fatigue are very common symptoms that relate to things that are going on behind the scenes with myeloma, which we can get into. But also patients can be bothered by frequent and long-lasting infections. So they find that they get sick more frequently than their family and friends, and they take a longer time to recover. That could be also a presenting sign. I think there can be some presenting signs and symptoms related to electrolyte abnormalities. Like some people may, especially in later stages, they might be nauseated or may have vomiting, be constipated, and also signs and symptoms related to cytopenias. You have to remember that this is a bone marrow cancer. So we do have some problem with development of normal blood cells. So we can see not only infections, but bleeding issues related to thrombocytopenia and factors related to anemia from low red blood cell counts. I think all of this is important to remember, but basically the most common presenting sign is bone pain or back pain and fatigue, but we can see other things as well.
Despite all of those potential symptoms that somebody could have, and I'm imagining that when you're talking about like for late presenting for nausea and things related to that, you're thinking maybe something related to hypercalcemia or bone destruction there.
Correct. Absolutely. And that's when, you go to a primary care doctor. Even when you go to a primary care physician and you complain of fatigue and even the back pain, invariably they're going to do some blood work, right? They want to check your CBC and chemistry. Not always do we find abnormalities in these general lab tests initially, but that's the first step. And if somebody is really symptomatic, you can likely see maybe some elevations in the calcium and maybe some renal dysfunction as well.
So despite those symptoms that you could see, many patients still present as asymptomatic for multiple myeloma. How can you explain or how can you help healthcare professionals identify patients in those situations?
And this is really an important point for everyone to remember. About 20 to 25% of our patients who are diagnosed are asymptomatic. They have no symptoms. They are living their life. They're going to work or they're traveling, playing golf on the weekends, taking care of their children or grandchildren. They are just living their life. And at times, they go to the primary care physician and then they're referred to a hematologist, oncologist, and they are pretty surprised when they're sent to a cancer center. The way they are sort of diagnosed in this matter is that their lab work, their routine lab work, the CBC may be normal, maybe some slight differences in their hemoglobin. But what we see in the chemistry, the complete metabolic panel, is an elevation in their total protein and or an elevation in the total globulins. So if we think about myeloma as a disease of the plasma cell, which it is, the plasma cells produce immunoglobulins or antibodies. And when they are secreting this substance into the blood, it makes the blood very viscous, and it's a protein. So these are proteins. This will raise the total protein of these patients. So initially, the doctor might say, the primary care provider might say, oh, okay, you had an elevated total protein. They're not going to run and start treating you for myeloma based on a elevated total protein. But it definitely warrants further investigation because actually inflammatory conditions, infections, autoimmune conditions, a lot of things may cause an elevated total protein, but it should not be ignored. So maybe the physician would say, come back in 4 to 6 weeks, let's repeat it. But if you see an upward disturbing trend in the total protein and or globulins, that warrants further investigation. And these, again, are your patients that are totally asymptomatic. They have no complaints. So then the physician would definitely want to see, well, what is that total protein? What is the elevation? That's when they would do additional diagnostics, different lab work, to try to identify what protein is elevated and what the diagnosis may be. And that's where we would do the myeloma panel, the specific myeloma blood work that can identify this abnormal immunoglobulin.
So that segues perfectly into the next question I have for you of explaining what some of that lab work is. I think one of the things that I've been fascinated with over the years as a hematology nurse is that all of the different things that we're looking at with myeloma that we don't look at with any of our other oncology disorders. So can you describe some of the lab work, maybe the biopsies, imaging studies, other lab that healthcare professionals will conduct to determine the diagnosis?
It's a very complex diagnostic workup. It does begin with basic blood work. So the CBC, the complete metabolic panel, that includes, LFTs, all the electrolytes. We do like to add a beta-2 microglobulin and an LDH. These are sort of indirect markers for tumor burden. And the beta-2 microglobulin is also a biomarker that can accumulate in patients with renal dysfunction. So we do want those lab tests. And if a patient does have myeloma, those results are crucial for staging purposes as well. So we do blood work, actually not only blood work, but it's very important to get urine studies as well. And we prefer not to do a random urine, although we can do random urine testing, but it's nice to get a 24-hour urine collection and to test the 24-hour urine collection for protein studies as well. So we do that. We do radiological studies. The skeletal survey used to be the universally accepted standard for imaging, but that has really sort of gone by the wayside. We have the whole body low dose CT scan, CT bone survey, which is really much preferred to detect lytic lesions in these patients. We can do MRIs of the axial skeleton, especially if patients are complaining of specific back pain or hip pain or any other kind of discomfort in their bones. PET-CT scans are also now approved and authorized by most insurance companies for diagnostic purposes for myeloma. I think the most important test that we have to speak about is the bone marrow biopsy. So the bone marrow biopsy serves many purposes. You want to determine the percent of bone marrow plasma cells. So you want to get the degree of plasmacytosis. And then you want to do really specific tests on those plasma cells. So you want to isolate the malignant plasma cells and determine via analysis. So we do the karyotype, we do chromosomal studies, we do FISH studies, we do immunohistochemistry studies, we do molecular studies. All of these studies are looking for specific genetic changes in the myeloma cells, looking for translocations or deletions. And it's very important to get that information because we can put patients in a category of having standard risk disease versus high risk disease. And that can give us a better picture of what this patient's journey with myeloma may look like.
So I think you've answered most of my next question because you were talking about different tests that we're doing and then with risk stratification. But is there a little bit more detail that you can give us about biomarker testing that is specific to multiple myeloma and the risk stratification?
There are a few very specific markers that we look for myeloma, and there's a very lengthy list, but I want to go over just some of the important ones. And again, you have to remember, just like with solid tumor malignancies and other heme malignancies, we do neogenomic sequencing or molecular studies and all this other genetic testing. And these diagnostic tests are crucial to give us another sort of a profile on the risk stratification for the patient and its resultant prognosis. But some of the things we're looking for that will lead us to believe a patient has high risk myeloma are certain translocations like T414, T1416, and T1420 are associated with a higher risk disease. And there are certain translocations like T614, 1114 especially. That's sort of a standard risk, so a better prognosis. In general, hyperdiploidy, when you're looking at the copy number of chromosomes, if you have hyperdiploidy, that's favorable, and hypodiploidy is unfavorable. And then we can look at translocations. There are many translocations that are associated with high-risk disease status, some of them being 1q21 gain, 1p deletion, the 17p deletion, just like in many, many other malignancies. A 17p deletion is associated with a poor outcome. A 13q deletion is sort of on the fence, sort of like a seesaw. It could be standard risk, it could be high risk, but definitely a 17p deletion is one of the poorest prognostic risk factors for patients with myeloma.
So pulling a few of these things together that I didn't put in a question for you earlier, but thinking about, you talked about risk factors and how this is normally a disease of the older person and that many people can present asymptomatically because it's been quiescent and it's just been quietly growing. You also have the people who are presenting with low back pain. Thinking about, say, your 35, 40-year-old, the much younger person, that they're probably going to toss off that low back pain because maybe they're an athlete and they strain their back or something like that. Are patients who are younger when they're diagnosed, do you find any specific biomarker stratification that goes with them? Are they at higher risk? Do they have more advanced disease?
Solely based on age, there is none. There is nothing I can't say to you, Lenise, oh, so this 35-year-old presented, and just because of his or her age, I have to be more cognizant of a certain translocation or a certain deletion or whatever. No, it's really not an age-related factor. We test all patients for all of these aberrations. We test them for all. But I just think that in going with your saying, I think if we have a much younger person, if we do have a 35-year-old with high-risk disease, of course, that's more upsetting because, listen, it's always upsetting to have a patient with high-risk disease, whether they're 35 or 65. With somebody who's 35, we have to start thinking about outside the box kind of and thinking about treatment options that might not be available for a 65 or 75-year-old, that might be available for a 35-year-old to perhaps lengthen his or her life. So it's not an age-related factor, these genetic abnormalities, but it does make us think, especially with somebody with high-risk disease. So just so I want to make it clear, we treat everyone. Everyone gets treated. Just about everybody responds. There's a very high response rate based on our current novel treatment options. But we know from experience and from clinical trials and statistics, we know that patients with high-risk disease are likely not going to be in remission from these treatments and for a lengthy period of time, unlike the patients with standard risk disease. So we have to keep thinking in our heads, the wheels have to keep turning in our brain. What's the next step? What's the next step? What are we going to next? Because we know these patients will usually relapse quicker and likely more aggressively than their standard risk patient counterparts.
Can you talk a little bit about the difference between an active myeloma as opposed to the MGUS that you mentioned earlier, the benign precursor that may require some monitoring, but maybe not immediate treatment?
So there are actually two benign precursors, MGUS and smoldering myeloma are both benign precursors of myeloma. And when I say benign precursors, I mean they don't warrant active therapy. Although smoldering myeloma has undergone a change in its definition over the last 10 years, when we're talking about MGUS and smoldering myeloma, in general, these are patients that have a little bit higher percentage of plasma cells in their bone marrow. So they're not a normal patient that has 2 or 3% plasma cells in their marrow. They do have a higher percentage of plasma cells. They also usually have an M protein in their blood. They do have the presence of this monoclonal protein in their blood, but they don't have any end organ damage. They don't have any symptoms. They don't have any other organ dysfunction that tells us, oh my goodness, we have to start treating this person right away. So those are the patients where the MGUS and the smoldering myeloma, we kind of watch and wait. And a lot of patients don't like that term watch and wait because they'll say, well, I have a cancer, even though it's not active yet, you're just going to sit down and do nothing, and just watch me. But we watch these patients very closely. And now we don't even use the term watch and wait anymore. I think active surveillance is a better term. It sounds a little better than watch and wait. I think patients get a little nervous, but I always tell them, we're still not doing anything. We're going to have you come back on a regular basis. We're going to repeat your labs, repeat your 24-hour urine, maybe repeat imaging, depending on your presentation. But we just follow these patients very closely. And I think it really, especially with the MGUS, which is a much lower percent of plasma cells. And, as we age over 50, about 3% of us have MGUS. Over 80, it's a much higher percentage. I mean, it just kind of happens. It can happen. And I think patients knowing about this just presents them with a lot more things to worry about every so often. It just causes more anxiety than ever because a lot of these patients with MGUS, the vast majority of them will not develop into myeloma. The risk of developing myeloma is only like 1% per year for some years, and then it's negligible. Even for smoldering myeloma, the risk is like 5% per year for the first 5 years. Then it goes down to 3%, then down to 1%. So as you live on with these benign precursor conditions, the risk of getting myeloma certainly does not increase. It kind of goes on a downward trend a little bit. So active myeloma is when we have a patient who has symptoms. They have evidence of end organ damage or injury. So these are the patients with the lytic lesions. They have holes in their bones. They are anemic. They're anemic from their myeloma. So it's not from a GI bleed or from iron deficiency. They're anemic because we've ruled out every other cause of their anemia, and it's due to this monoclonal protein. Or they're hypercalcemic, or they have kidney dysfunction. They have acute kidney injury, and that we're attributing to this monoclonal dyscrasia. So those are the patients we are treating actively earlier rather than later. So we want to get on board with treatment with those patients right away.
I love the term of active surveillance because that does make somebody think that we're actually doing something, even if we're not giving them a medication.
I did want to bring up one other point. There's actually now a new definition of our smoldering myelomas because I mentioned that there's been a change in the last decade. So we do have, the IMWG about 10 years ago came up with new guidelines for defining which patients need active treatments. So we used to go strictly by the CRAB criteria. And that was basically based on a patient's calcium level, their creatinine level, their hemoglobin, and the presence of bone disease. But now we've also incorporated other factors that will lead us to believe that even though patients are not symptomatic, it's recommended that they start treatment right away. And those patients are the ones where we do their bone marrow and they have 60% or greater plasma cells in their marrow. They have a serum free light chain ratio of over 100. So that's another diagnostic lab test that we do for patients with myeloma. It's a protein study. And then we also look at the MRI. If they have one or more focal lesions that are at least 5 millimeters, that also portends for initiation of active treatment. So we have to redefine what constitutes active myeloma a little bit. We tweaked it a little bit over the last 10 years. So I just want to bring that up because it's kind of important.
Yes, very definitely. How might the nurse best support a person that's diagnosed with multiple myeloma?
We as nurses and nurse practitioners, I think our biggest role, our most admirable role is patient advocate. We always support our patients. And I think that just being there to answer the patient's questions is really number one. Just like any malignancy or any cancer diagnosis, this is a life-altering event. And I think being there to answer all their questions is first and foremost the primary concern. And if you can't answer a patient's question, I never pretend to know everything. Nobody knows everything. So if I can't answer a question, I'll always tell a patient or a caregiver, I really don't know the answer to that question, but I'm going to find out and I'm going to get back to you. So they might have questions regarding their disease, regarding their potential treatment options. But in general, I think that the best way that a person, a provider, a nurse can support a patient being diagnosed with myeloma is to listen to them, to stress certain things like protecting their renal function, knowing when and why and how to report signs and symptoms of infection, to be diligent about dental health and certain other things like be aware of shingles. And I just think overall health issues, to be very cognizant of that is the best way that we can support somebody with newly diagnosed multiple myeloma.
I know that for so many of our solid tumors, there's the risk for infection, but it's a different risk for infection than it is with any of our heme disorders. And when you add in the difficulties with a person's immunoglobulins, I think that adding in that piece about shingles, because what 40-year-old thinks that they're going to get shingles?
What I also would like to mention, Lenise, is if patients call this a bone cancer, I can't tell you how many times I've been with a patient and they say, yes, I was diagnosed. I overhear them talking. I was diagnosed with a bone cancer. I always correct them. It's a bone marrow cancer. And it's a little bit different because your bone marrow is a factory for your blood cells. And I kind of explain that to them. But really, if you think about this is an immune system cancer. This is an immune system malignancy. And if you tell a patient that and you explain about their immune system, then they can understand why they have to be so in tune with infections, when and how and why to report any fever, cough, any sign or symptom of infection. So it's really an immune system cancer. And I think that's important to bring across to our patients and the caregivers who are helping take care of our patients.
Exactly. Turning it just a little bit, because a bone cancer, I could break my bone, but this is something where I could die from sepsis.
Absolutely correct.
There's been a lot that's been happening in the cancer community recently around treatments of cancer. And I know that we've all been super excited about some of the things that have been coming along for multiple myeloma. What are some of the specific advancements that have been made in identifying multiple myeloma, and what does the future look like?
There's been a ton of advances in the whole world of myeloma. You can talk about diagnosis and treatment and diagnostics. It's been so much. But I think that honestly, if I had to pick like maybe one or two things that stand out as advancements in identifying myeloma, I think two of them would be our MRI bone marrow blood supply. So it's an imaging test. It's an MRI that really shows how well the marrow is perfused, and it can really help detect cancer. So that's really one of our newest MRI. I mean, it's been around at our facility for quite a number of years, but I think for some other communities, it might not be available. But that's one of our new imaging tests that can help identify myeloma. And when I think about other diagnostics, I think that we have so many more precise methods to detect circulating tumor cells. So I think the new buzzword in hematology malignancies is the blood-based liquid biopsy. It's like you can take a blood sample and detect DNA from the malignant cells at levels that are so minute. And you can tell if a patient's on the verge of relapse or whatever, or they're responding and they're in remission. I think that is such a wonderful idea. As a matter of fact, I don't know if it'll happen in my work lifetime, but maybe this kind of diagnostic testing can eliminate some of the bone marrow biopsies that we do. When I used to work in lymphoma, I spoke with the physicians who were lymphoma specialists, and they said that they foresee a future in having these assays that detect circulating tumor cells actually take the place of imaging studies like restaging PET-CT scans. So it's really amazing, these tests that are actually on the market now and not maybe as widespread as we'd like, but there's a lot of nice assays out there that will become more popular, used more commonplace in the future, that I think are going to help identify myeloma more precisely.
That's kind of like science fiction from...
Yeah. Especially when you think about you know what, Lenise, if you think about myeloma, like even with MRD for leukemia, for lymphoma, you take a blood sample, you test it for MRD. For myeloma, you need a bone marrow biopsy. You need a bone marrow sample. You can't do MRD on a blood sample for myeloma, not yet. But if we perfect these assays and we can eventually maybe detect this, then you're looking at a whole new ballgame. You can even, perfect your MRD testing as well. So it's really in a very exciting time for some of these heme malignancies and making it better for patients and more precise, detecting relapse or assessing response and assessing remission. I think it's very exciting.
Okay, I have a few more questions for you. How can healthcare professionals identify some of their own unconscious or implicit biases in relation to multiple myeloma or the patients receiving care?
This is a tough question. We don't like to think of ourselves as having any bias. I think that as nurses and providers, we never like to think that we do have any biases, but Most of the time in the field of myeloma, the biases are related to race and ethnicity and socioeconomic status. So, as I mentioned in the very beginning of this podcast about how there's a very big disparity in race for the patients with myeloma, it's twice as common in patients of African descent than in the white or other racial backgrounds. I think it's just very important to be cognizant that, and it's not always a socioeconomic factor with the Black population. It could be related to hereditary and biological factors as well. But this can lead to, we have these biases, it can lead to delayed treatment, reduced access to advanced treatments and care. I think it's very important to realize, and you may know this already, a lot of you, but this can also lead to less involvement in clinical trials, which is a very important factor. I think that we can only find out about treatments and response to treatments in the Black population, in the Latino population, in the Asian population. We can only figure these things out by having more patients of these backgrounds enroll in clinical trials. I think by us having these biases, it may accidentally, I think that's a good word, it may accidentally maybe lead us to not having patients involved in clinical trials, or maybe not having them be chosen or considered, that's even a better word, considered for some of these advanced treatment options. So I think that's where we have to be very cognizant about the way we deal with patients. You want to have equal access. And if we have equal access for everyone, I think it leads to good outcomes across all the racial groups. If we can make everybody have the same kind of access to care, we can have great outcomes for everyone, for all people, regardless of their racial or ethnic or socioeconomic background. It is challenging, but we can do it.
That's a really good point. And the point about clinical trials, the amount of press that's been around for the last couple of years thinking all of these medications have been tested on Caucasians, and the Blacks, the Latinos may not be having the same responses because we didn't know what their response was.
And of course, if you know anything about the history, I think that especially in the Black population, there's just a lot of mistrust of the medical community based on very truthful things that happened in the past. But we have to try to overcome that. We have to speak to our patients, speak to the caregivers, tell them about the advancements in clinical trials, tell them about how they're very strictly regulated now. And I think getting them enrolled in clinical trials is going to be our answer to find out, like you said, how people respond across all different backgrounds.
Exactly. What are some common misconceptions about multiple myeloma?
As being a nurse practitioner in a very busy multiple myeloma practice, we see a lot of young patients. So I think one of the misconceptions is that it is strictly a disease of the older person. You can't just say, because your patient is 35 years old, that you can't consider a diagnosis of myeloma, that we should, because it can occur in younger patients. I think one of the other misconceptions is that it's a curable disease. It is very treatable, very manageable, but at this point, it is not considered curable in every sense that I can talk about. I mean, I hope in the future, we are working on a cure. I hope in the future, in my lifetime, I would love that to happen. But right now, it is still considered an incurable disease. The reason I like to mention that is because patients need to know that autologous stem cell transplant is not a cure. They will relapse. We can't tell them when, but they will. We have to tell them that just because they're on a treatment that puts them in remission, if they stop treatment, there is a risk they're going to relapse. The problem is we can't tell them when. So patients are on this journey with myeloma for the long term. We know these patients for the rest of their lives. We might not see them so frequently at certain points in their life, but we know everything about them. We know where they love to travel. We know where they work. We know their kids and their grandkids and what wedding is happening and everything. We know everything about them because they're with us for a very long time. One of the other misconceptions that I hear a lot, basically from my patient population, is about diet, about a recommended diet for myeloma. And I always tell patients, look, with any cancer, we want you to eat a healthy diet. There is no specific diet that's going to manage myeloma. In general, we just recommend a very healthy diet, of course, with certain things in moderation, sugars in moderation, alcohol, and sometimes no alcohol at all, but just eating overall healthy. Some people like the Mediterranean diet. Some people are going plant-based. Anything that works for you is good, but there is no specific diet that is going to cure myeloma. And I do hear that kind of out there, even on social media. So it's just something that I need to tell everyone, that a good, healthy lifestyle with rest and sleep and exercise and good, healthy eating is in general recommended for patients with myeloma.
Thank you for saying that, because I know we've been seeing that a lot in social media recently. And I think it's really important to point out that you need to feed your body and you need to feed it healthy. It's a partnership.
I think all of us, not just patients with cancer, I think all of us need to just be very aware that our body is our temple, right? And we just have to make sure, that we are feeding it good stuff.
What's something about this topic that's not often discussed, but you wish people knew more about?
If I had to name one thing I wish people knew more about, is the very important psychosocial and financial burden that not only occurs with myeloma patients, but all cancer patients, but specifically, I think, with myeloma patients. The financial burden is, I think, a lot of practices or providers, we may know about it, talk about it briefly, but we really need social worker as part of our team to address this. These medications, especially the oral medications, which are very prevalent in myeloma, they could be very expensive. Now we're talking about not your health insurance plan, but your prescription plan. People may have to be out of work for certain reasons and certain length of time. I just think there's an overall sort of the wallet toxicity. I like to call it the wallet toxicity that we should be very aware of, and the psychosocial issues. And when I talk about the emotional toll, just remember that in myeloma specifically, steroids, specifically dexamethasone, is a very important part of the treatment regimen with all of the options for managing myeloma. So dexamethasone works synergistically with many of our agents to enhance the response rate. And as we know, dexamethasone not only has a lot of physiological side effects, but has a lot of emotional side effects. We can see, irritability, depression. I think it's very important for patients and caregivers to be aware that some of their personality, in quotes, may be temporarily changed. And it's not really them, it's the medication that's causing it. So I think that's really important to realize.
Very important. Dosing it appropriately throughout the day so you're able to sleep at night.
Oh, yes, absolutely.
And then going back to the wallet toxicity, I think one of the things that I've been hearing very frequently from previous guests and from speakers at conferences is making sure that you're not doing a one-time approach to figuring out if they're handling their finances okay, but it is a repeated topic that you bring up to make sure that they can still afford these medications, that they can still get their food, pay their rent.
That is very important. And I'm so glad you brought that up, Lenise, because think about it. Some people get diagnosed before they're on Medicare. And then all of a sudden, and I remember I said, this is a lifetime journey for them. So then all of a sudden they're Medicare eligible and their whole insurance changes. Are they still going to have the same resources to get medication, to get treatment? I think very important. Some people have job changes. They move. I think that's crucial. You can't just do a one and done. Let's talk about your finances when you're diagnosed, but then 6 years later, while you're still getting treatment, not bring it up again. And that's where I think in most of the academic settings and even in the community settings, I think there's a social worker available that will address this periodically to make sure the patient's, not suffering from this financial burden. So that's important.
What additional training or education do oncology nurses need to stay current on this topic?
So I think not only on this topic, but I think the most important thing regarding training and education for oncology nurses is to really try to stay abreast about the new treatments. But if you think about oncology in general, there are new treatments coming out every single day. It's really difficult to keep up to date. I'm an ONS member, so I get a lot of emails from ONS, or even the FDA will send out blurbs, email blurbs if something's been approved. I think that it's important to try to stay up to date as much as possible. I think one of the ways specifically for myeloma is that the ONS has a lot of resources. I think the IMF's Myeloma University is an excellent resource. There are a lot of nurse-centered resources for myeloma. If you just look on your smartphone or if you Google, myeloma for nurses, so many things come up, so many different educational resources come up that you should take advantage of to sort of keep abreast with what's going on in the myeloma world. And not only to know about the treatments, but more importantly, because patients will ask the nurses, what are the side effects? What's going to happen to me? What can I expect to experience? So learning about the treatment, maybe not so much all the science that led to the approval, but what kind of dosing schedule is this? What kind of side effects can my patient possibly present with? And how do I manage that? That's the kind of things that we want to have nurses stay up to date with.
Exactly. So they can provide those resources and not have the patient have to go searching on the internet to find something that matches what they're thinking. You mentioned ONS and you mentioned the International Myeloma Foundation. What are some of the other additional resources for patients and other healthcare professionals to learn more?
So I always, and this is a very common question that I get because and not only from nurses, but from patients, patients will say, well, my daughter, since I got diagnosed with myeloma, my daughter went online. I cringe. I just cringe because there's so much great information online and there's so much good stuff. But in that same breath, Lenise, there's so much junk out there that is not really reputable. So I really tell patients and nurses, because a lot of these websites, I always steer them to the reputable websites. And most of these websites, and I'm going to mention 3 of them, but there's many out there, many. If you go on to, let's say, an IMF website, you'll see if you go onto the IMF website, and that's an International Myeloma Foundation, or even the MMRF, or even the LLS, which is now called something else now. And for some reason, it's blanking because now it's a different name for the LLS because they've incorporated all the blood cancers, including myeloma, in their title. But if you go on their website, you'll see like a choice. I am a provider or I am a nurse. And then on the other side, it'll say I am a patient or a caregiver. And if you click on that appropriate choice, you'll get very patient-friendly or nurse-friendly information to help you navigate whatever your question or whatever your investigation may be, whatever you're looking up. So it's really important to go on the reputable websites.
It's an excellent point. And the Leukemia and Lymphoma Society is now the Blood Cancer United.
Blood Cancer United. Thank you, Lenise. I know my mind is like, I just forgot. I knew it was because now they've incorporated all the blood cancers. Those 3 for myeloma, I think the IMF, MMRF, and the Blood Cancer United, those 3 foundations, if you want to call them. Well, listen, there's a lot of them out there that are very reputable. The American Cancer Society, there's so many, NIH. But I think that those 3 I mentioned are very geared to focusing on blood cancers, especially myeloma. So you can get more information maybe than the other sites. So I think it's very important to know that.
Excellent. And it has been absolutely wonderful talking with you. And I hope I get to do it again soon. Do you have any final comments for us?
I think that it's important to realize that patients with myeloma will be with us a very long time. I think I mentioned that before. So it's very important for us to realize that during their journey, we will see them repeatedly. Like I said, maybe not so frequently in the beginning or in the middle or at the end, whatever, but they are going to be part of our work family. They will be with us for a while. And I think it's our job to be their advocate, to be really focused on not just them as a disease, but like you mentioned before, periodically assessing that financial burden and periodically assessing the psychosocial aspect of the diagnosis is different for a patient with them when they're in the remission than when they're relapsing or maybe at the end of life. It's all a journey that is very challenging for them. So we should be aware of all of that, periodic assessments.
Excellent point. Thank you so much. And I hope you have a good rest of your day.
Oh, thank you, Lenise. Thank you so much. It was my pleasure.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.